So we'll talk about adrenal insufficiency, a little bit about what is adrenal insufficiency, how you differentiate between different types of adrenal insufficiency, but primarily focus on management of sick days and adrenal crisis. So what do we know about adrenal insufficiency? So it's a lifelong replacement treatment. So most patients who are diagnosed with adrenal insufficiency have to take cortisol replacement therapy for lifelong. And that is quite a complex treatment regime with several tablets often a day and adjusting the medication during sick days and obviously preventing adrenal crisis. So there is a high risk of adrenal crisis associated with adrenal insufficiency. So the impact on patients, but also the health service is quite severe. We know from previous research that 1 in 6 to 12 patients have a hospital admission every year from adrenal crisis, most of them potentially preventable, and also significantly 1 in 200 people die from an adrenal crisis, also potentially preventable. But one thing that we tend to forget is that these people have, most people who are here today may have impaired quality of life, and there's a high prevalence of unemployment. So the day-to-day impact of adrenal insufficiency is quite significant, as well as the impact of adrenal crisis. The other thing that is not very well researched is the bigger picture. We know in the UK there are about 25,000 patients with diagnosed adrenal insufficiency because of pituitary or adrenal problems. However, there are about 500,000 patients on corticosteroids and immunotherapy at a time who are at risk of adrenal crisis because of suppression of adrenal function. So this is a much, much bigger problem that we are actually not very aware at this point. And there is a lot of work that needs to be done. So as you may be familiar, the adrenal gland sits just above the kidneys and is controlled by the hypothalamic and pituitary axis. So this is a graph of the adrenal gland and the pituitary and the hypothalamus. So if you imagine what we call the feedback loop, if the adrenal function works well, then the pituitary stimulates continuous production of cortisol. If there is a problem, so if there is a stressful situation, then the pituitary can detect that, and the adrenal produces more cortisol to cope with stressful situations such as physical or emotional stress. If, however, there is a problem with the pituitary or the hypothalamus, no, don't want that. There is no stimulation to the adrenal gland. So even though the adrenal gland is working in theory well, if there is no stimulation to it, then it doesn't produce cortisol. And that's what we call the secondary adrenal insufficiency. So when the problem arises in the hypothalamus or the pituitary. So effectively, the adrenal goes into atrophy, so it doesn't work because there is no pituitary and hypothalamic stimulation. Now, if the problem is in the adrenal gland, then the pituitary and the hypothalamus will detect that, and it keeps producing ACTH, which is the stimulating hormone, but obviously, with the adrenal gland being in failure, nothing comes out of it. And this is why we see high levels of ACTH in primary adrenal insufficiency. And obviously, when there is a treatment that suppresses the adrenal gland, it can suppress the hypothalamic function and the pituitary function. Now, the management of adrenal insufficiency is with daily replacement with glucocorticoids, so most commonly hydrocortisone, as you may know. But for people with primary adrenal insufficiency, they also need mineralocorticoids, so fludrocortisone. It's important to adjust the dose of glucocorticoids during physical and emotional illness, or what I mentioned earlier about increased level of stress. And it's important to prevent and manage adrenal crisis. So if sick days or the body doesn't have the level of cortisol to cope with the stress, then that leads into an adrenal crisis. So self-management strategies are very crucial for patients with adrenal insufficiency. One thing I always say to my patients is, you see clinicians and you see endocrinologists probably 15 to 30 minutes every 6 months, every year, but you have to live with the condition for the rest of the year. So being able to manage your condition is extremely important. And as clinicians, we need to provide you with those strategies. And adrenal insufficiency, as I mentioned earlier, interferes with day-to-day lives. And so this is a rather outdated study, but quite a large study, which shows that almost more than 60% of patients reported that adrenal insufficiency interferes with their work life, their social life, or their physical activity. And that's across all types of adrenal insufficiency. So what is the purpose of treatment? The objective of treatment is, of course, optimal replacement, and that it can improve the quality of life, well-being, and treatment adherence, and less concerns and adverse events. So if you take too much glucocorticoids, too much hydrocortisone, then that leads to side effects and long-term complications. If you don't take enough hydrocortisone, then that obviously brings the symptoms of adrenal insufficiency and impaired quality of life. So I mentioned the most commonly treatment that we use for adrenal insufficiency is hydrocortisone tablets. Most people with pituitary conditions will take hydrocortisone 2 to 3 times daily, split in doses such as 10, 5, and 5 milligrams, or 10 and 10. But this can vary vastly from individual to individual. This is a chart that shows the normal level of cortisols, the rhythm of cortisol production, and you can see that the highest level of normal cortisol in yellow here are first thing in the morning, so between 4 and 7 in the morning, and then it starts to drop throughout the day. What the hydrocortisone does, however, because it's a short-acting tablet, you take it on waking up, and it gives you a spike of cortisol, and it's out of your system within 6 to 7 hours, and then you take the second dose, another spike, and the evening dose, another spike. So that means that depending on the time you can take the hydrocortisone, you get the highs and lows. Some people get highs and lows associated with levels of cortisol, and many people may also report afternoon crash or lunch crash. One thing that we also sometimes fail to advise our patients on is the drug interactions with glucocorticoids. And it's very common to change treatment, but actually not change the dose of hydrocortisone. As an example, if you are on oral estrogen replacement or the contraceptive pill, that increases the circulating cortisol binding globulin. And if you come in clinic for a cortisol level or a test, then that will show false high plasma cortisol levels. So that's quite important to remember. Also some herbal remedies like St. John's wort or foods like grapefruit or licorice that can increase the bioavailability, so it makes the hydrocortisone more potent. Coming on to the management of sick days, this is a simple graph which you can access from the Society for Endocrinology, and it's 3 areas that we focus on when we talk about sick days. It's the moderate to intercurrent illness. So this is when you have an illness that is managed at home, or such as a fever, infection requiring antibiotics, surgical procedure under local anesthesia. And in this case, you need to adjust the dose of your hydrocortisone tablets or prednisolone, if that is the case, to support your body to cope with that additional stress caused by physical illness, but also emotional illness. So emotional illness is something that has not, again, been researched widely, and there is, among clinicians, there is quite a variable opinion on how you manage emotional illness. But that is one of the causes of potentially triggering adrenal crisis, and it's really important to manage it. The sick day rule 2 is related to severe illness, especially persistent vomiting. So vomiting is the main trigger of adrenal crisis, but it's also a symptom of adrenal crisis. So if you have vomiting, persistent vomiting, then that requires hydrocortisone injection, and that can be given intramuscular by an injection, or it can be given intravenously. Similarly, any situation such as very high fever, very unwell, or situations where you can't keep your food down, so vomiting, or during a preparation for endoscopy, for colonoscopy. So anything basically that is related to I cannot take my tablets, I cannot keep my tablets down, requires an injection of hydrocortisone. And that is really important to be administered very promptly, as soon as the symptoms kick in at symptom onset. And then obviously with that, it is important to remember the patient education, and as clinicians, we our obligation is to ensure that you are familiar with the sick day rules for both adjusting the dose of glucocorticoid, but also when you need to inject hydrocortisone. So what are the situations that you would tell yourself, now I need a hydrocortisone injection to prevent an adrenal crisis, but not be too late to the scenario where you are unable to inject yourselves. This, again, I find is a really useful leaflet. You probably won't be able to see it in your screen. I'm sure you won't be able to see it in your screen. The writing is very small, but it's available from the Society for Endocrinology. The Pituitary Foundation also has a similar leaflet, and it's a brief introduction to what are the sick day rules, what is an adrenal crisis, and different situations where you need to adjust either the dose of your tablets or when to have a hydrocortisone injection. That's another example from one of our publications. And as an example, when you, for example, have a long haul flight, so this is increased stress situations or events, or a long haul flight, or you are very active and you are training for a marathon, that's when you need to take an additional hydrocortisone tablet. Similarly, you can adjust the dose of hydrocortisone depending on your work pattern and your day-to-day pattern. So weekends, for example, if you have a day out or a long day, then you can take an extra tablet to ensure that you're covered with cortisol while you're active and awake. Shift working is another area. So the idea really is that you have cortisol in your system when you're active and awake. Ramadan fasting is another area where you need to adjust the dose of your hydrocortisone, and in this case, we suggest that you switch to a long-acting glucocorticoid. So in this case, would be prednisolone or a long-acting hydrocortisone, that it can last much longer and cover you for that fasting period. For illnesses such as a minor dental procedure, you can take an extra tablet, 10 milligram hydrocortisone before the procedure, and depending on the symptoms or pain, you can continue on either double dose or an extra tablet after the procedure. The more severe illnesses is when you will require, as I said, a hydrocortisone injection. Just a couple of examples from what I mentioned earlier. So these are two of my patients. The names, of course, have been changed. And Richard is a gentleman, 54 years old, and has secondary adrenal insufficiency following a pituitary surgery. He takes hydrocortisone, 10 milligrams in the morning and 5 milligrams at lunchtime. And he volunteers as a coast guard and is often called on emergencies in the middle of the night. So he described that as a very stressful physical and emotional situation. And he comes back home and he tells me that he's very exhausted the next day. And on one occasion, he developed an adrenal crisis and needed a hospital admission. So in that case, after discussion, it transpired that he wasn't taking an extra dose of hydrocortisone before going out as a coast guard. So that's really important to remember, that if you are in very high stressful situations, both physically and emotionally, to take additional hydrocortisone. Now, these are two students so Salma has Addison's disease. So this is a primary adrenal insufficiency due to adrenal failure. And she tells me she experiences severe perspiration, hot flashes, tachycardia, dizziness, and anxiety. And she finds it impossible to focus during her exams. So she's not doing really well in her exams because of the stress caused. And the next day, she also feels exhausted. Now, Kay is another patient who has congenital hyperpituitarism. So she was born without pituitary function, and she feels slightly anxious, she says, but she's doing very well in her exams, no problem on her hydrocortisone 10, 5, and 5 milligrams. So we have exactly the same situation in a way, the same treatment, but two completely different people. So in that case, I advise Salma to take extra hydrocortisone tablet before her exam and maybe after her exam, depending how she feels. And that really worked, and she does very well in her exams. And obviously, Kay is not affected by it, so there's no need to change her treatment. So management of adrenal crisis, the advice here is always treat first, diagnose later, and that's really an advice for healthcare professionals, but also for patients, because it's really important. Having an injection of hydrocortisone will not do you harm, but it may not having it may lead to a hospital admission or even be fatal. So it's really important that on suspicion of adrenal crisis to inject hydrocortisone. Symptoms of an adrenal crisis, people describe it as a profound lack of energy and general weakness. So many of my patients say, I know when I have an adrenal crisis, and others will say, it's so unpredictable. It just comes so quickly that I don't know what to do. I don't realize that I am getting an adrenal crisis. Nausea and vomiting. So as I mentioned earlier, vomiting can be a symptom of adrenal crisis, but it can be the main trigger of adrenal crisis. So if you find you vomit more than twice in a 30-minute window, then that's really important to manage and have a hydrocortisone injection. Obviously, with vomiting, if it is a symptom of adrenal crisis, it will improve after a hydrocortisone injection, but if it doesn't improve, then the hydrocortisone injection will effectively buy you time to get to the hospital to manage whatever is causing the vomiting, so food poisoning or gastroenteritis. Also, high fever, low blood pressure, hyponatremia, low blood sugar, are also symptoms of adrenal crisis, and it can lead to confusion, delirium, and at a later stage, if it's not treated properly, it can lead to hypovolemic shock, kidney failure, loss of consciousness, and coma, leading to cardiovascular failure and death. So these are very extreme cases, but this is the risk of an adrenal crisis if left untreated. So again, the treatment for adrenal crisis is the only treatment is injection of hydrocortisone or intravenous through the vein in infusion hydrocortisone. This, I hope you all have access to, is the steroid emergency card, the NHS steroid emergency card, which was developed by the Society for Endocrinology in collaboration with the Pituitary Foundation and the Addison's self-help group. And it's something that can give the clinician or your family and friends the information they need, what needs to be done during an adrenal crisis. Obviously, managing a hydrocortisone injection during an adrenal crisis is a whole different subject, which I don't think we will have time to go into. And there is a lot of work being done currently to develop a simpler device, because we know 20 steps to prepare a hydrocortisone injection when you are having an adrenal crisis. I call it quite primitive. And I know many people find it really difficult to give an injection during an adrenal crisis. So hopefully the evidence we are collecting and the work that is currently being done will lead to a much simpler device in the not so distant future. So just very briefly, as Lottie mentioned, we started, and I say we, myself and my research collaborators, with the Pituitary Foundation and the Addison's self-help group, who are collaborators in this study. We developed a research project aiming to identify what affects self-management, so why people with adrenal insufficiency, what they find difficult in managing their condition and their treatment. And the aim is to develop an evidence-based program, an online program that can support patients and their families with managing adrenal insufficiency. So this is stage 2 or phase 2 of the study, which involved an online survey plus hard copies, I should have added that, of the questionnaire, aiming to look at how is adrenal insufficiency managed in terms of daily replacement, sick days, and prevention of adrenal crisis, and looking at self-management behavior. So what people do in managing day-to-day medication, sick days, prevention of adrenal crisis, and that was through a questionnaire which was developed from previous focus group interviews with people with adrenal insufficiency. We are also looking at experience of patient education and care service provision across the UK. And this is, it started as a study involving patients from the Pituitary Foundation, the Addison Self-Help Group, and CAH UK, but we then expanded on to endocrine centers across the UK with an incredible response, actually. So we now have almost 2,000 patients in the UK who completed the survey. and we have just started a European and international arm of the study, which is ongoing. So the survey from the endocrine centers has not yet completed, so I haven't analyzed the data. So these are just a snapshot of data from the 743 patients from the Pituitary Foundation and the Addison Self-Help Group. And one of the questions we actually asked, and that was a real eye-opener, was what is the cause of your adrenal insufficiency? And we presented 3 different options, or 4 rather. So primary adrenal insufficiency, secondary adrenal insufficiency, long-term treatment with high dose of steroids, and another optional response was, I'm not sure what caused my adrenal insufficiency. It was quite, as I said, quite an eye-opener, as people didn't know, many people didn't know what caused their adrenal insufficiency, and were unable to place it into that 3-point categories or for type of adrenal insufficiency. So one of the questions to ask your endocrinologist or endocrine nurse is to clarify what causes adrenal insufficiency, because that is really important for your knowledge, but also for your management. And when we asked then people to describe the adrenal, so if they said, I'm not sure what caused my adrenal insufficiency, we asked them, please describe in your own words. And we recorded those responses, and you can see that another 50 patients described the condition affected the adrenal glands. So they said Addison's, and here the light blue is basically after recording the responses. So most people are taking hydrocortisone tablets, so 2 to 3 times a day. So 85% of people, with some taking the long-acting, the modified release hydrocortisone and prednisolone, 11%. We also asked what option describes your work life. So I won't go through all of the details, but here one of the things that was important was the high level of disability allowance and income. And 22% of people said that after diagnosed with an endocrine condition that caused adrenal insufficiency, they had to give up work or studies altogether. 24% had to reduce their working hours, and 8% had to change job or studies. So that is quite significant. And here again, you can see that almost half of the people responded having tiredness, fatigue, brain fog was very common as a symptom they were reporting on a day-to-day basis. Restless sleep was also quite significant, and that can potentially have something to do with how you take your treatment and your hydrocortisone. We also asked how many times people were ill, physical or emotional, in the past 6 months, and so you can see almost 30% had 2 or 3 times, were ill 2 or 3 times in the past 6 months, and they had to stay on double dose of hydrocortisone. So 55% of them stayed on double dose of hydrocortisone for 3 days. So that's the duration of the illness, basically. The very positive thing we found was that people were very familiar and aware of what to do during sick days. So all the responses were, so more than 60% of people knew how to take the hydrocortisone tablet during sick days and how to double the dose of hydrocortisone. And similarly, 80%, more than 8%, said that they have the relevant skills to manage sick day rules. Now, there's a little bit of a caveat here, because obviously that group is members of the Pituitary Foundation and the Addison Self-Help Group. So these are the people who are aware and get the information from the website. So experience and management of an adrenal crisis. Again, the positive thing we found was that 76% of people are using the steroid emergency card, and also the 91% have an injection kit, a hydrocortisone injection kit, and 61% carried with them. So again, that's really important. You may have an injection kit, a hydrocortisone injection kit, but unless you have it with you, it won't be very helpful during an adrenal crisis. And 50% of people, almost 50% of people, said that they recovered after giving themselves an injection or having an injection and did not need to go to the hospital. So again, that shows the significance of having a prompt hydrocortisone injection. Okay, so just to summarize, so the strategies I currently use for self-management are face-to-face education, and I hope many of you have attended one of those sessions. They're very effective at improving patient knowledge, strengthens the clinician-patient communication, and improves your self-management and empowerment to manage your condition. But they are quite costly. They are very resource extensive, and obviously it requires you to travel. And we have seen after COVID the impact of clinic appointments and delivering those sessions face-to-face. Also, the limitation to that is that you attend for an educational session, but a year later, you probably don't remember what you have learned. And it's really important to have yearly and regular updates. So I think I am a strong believer that in today's technology advancement, having input from digital and technology is really important to complement the specialist care, because it can improve self-management. We can provide online education and virtual face-to-face consultations. However, we need to make sure that we do not digitally exclude people. So I mentioned earlier that we also provided hard copies of the questionnaire because many people don't have access online. And most importantly, collaborate with patient advocacy groups for educational or lobbying role. And 80% of patients in the study said that they get all their information from patient support groups.